Hello, my loves, and welcome back to the Love and Science podcast. Today, we're going to talk about anti-Müllerian hormone and what it is not, and how we actually use it in clinical practice. So, I'm dating myself here, but when I was a second year OBGYN resident in New York City, it was suggested to me by one of my mentors that I give my grand rounds that year on anti-Müllerian hormone. Still at the time, it was actually still referred to as Mullerian inhibiting substance, or MIS. And virtually nobody had heard of this. I mean, it was something that people were starting to think about checking in the fertility clinics, but certainly was not as bread and butter as it is today. And so when I gave this talk to an audience of mostly general OBGYNs, it was kind of like, oh, that's so fascinating. When somebody presents something that's like maybe ahead of the curve, you don't know if it's going to have any relevance. But now, so many years later, I am really excited to explain to you how relevant it is in 2025, and also kind of the nuances, so that whether your AMH is high or low or somewhere in the middle, you can start to understand what it means for your health and maybe an asterisks your fertility. Okay. So what actually is anti-Müllerian hormone? So I'm a reproductive endocrinologist. It's actually a hormone, right? So it is a hormone that actually aids in development, like embryological development. It actually inhibits the Müllerian or uterine structures from being developed in a male fetus, actually, when everything is working correctly. It also is made by the granulosa cells of the ovaries. And so, very interestingly, we see that it is definitely present, during childhood. We see that it hits basically its peak around the mid 20s. And then over time, it slowly diminishes until menopause, where it's undetectable. So it's interesting. There was a study done by another one of my mentors that showed that when the anti-Müllerian hormone becomes undetectable, that menopause is heralded in like 6 years. And so, I think that's a very specific number, but I do think that there definitely is a correlation with, menopause and cessation of ovarian function, when the ovaries is basically a marker of ovarian reserve and how many eggs somebody has left. Okay. So interestingly, anti-Müllerian hormone also inhibits follicle stimulating hormone. So oftentimes we think about AMH as being very low, and what does that mean? But I think about it kind of the extremes, right? If anti-Müllerian hormone is super high, then if it's inhibiting FSH, then maybe somebody doesn't ovulate, like in the context of PCOS. So we do often see that FSH resistance, in the context, sort of oral med resistance, actually, to be even more specific. We see that people have this in the context of very high AMHs. It's a block to FSH. And sometimes, even despite letrozole, it can be hard to get somebody to ovulate. So anyway, so let's talk about, sort of variations in AMH, because I get this question all the time as a fertility specialist. Hey, my AMH was like 2.0 a year ago, and then I checked it again and it was like 0.9. Does this mean I'm falling off the curve? And I'm like, well, we have two data points to work with. We can kind of talk about it, but we do generally see a decline over time. Sometimes it's more rapid than other times. Other times we'll see the anti-Müllerian hormone actually go up. So somebody be like, well, it was 0.6 and I was really worried, but then, it was 1.8 and I felt more reassured. And so, like, what are we really talking about, and what sorts of things can cause variation over time? Well, one of the biggest ones is actually birth control pills. So many people are on birth control pills. I see this a lot in my patients looking into, freezing their eggs. And what we know is that the birth control pill can inhibit, kind of quiet the ovaries, right? And so over time, it can cause a reduced AMH. Now, is this clinically significant? I would say it is, because we do see that women who have been on long-term birth control pills can sometimes have a diminished response to ovarian stimulation. So, what I do is, if somebody has a lower than expected AMH, I usually have them come off the birth control pill, obviously with reliable contraception, if they are using the pill for contraception. And then I recheck the AMH in 3 months, because invariably we will see a rise. And that's usually just a hormonal effect. But if you give people's ovaries a chance to recover, oftentimes you can have a better stimulation. So I wanted to mention that, that sort of, we talked about it. Is it real? It's now documented to be a real effect. And I would say, you know, it can have a pretty substantial increase on the order of maybe 30% or so, sometimes even higher. Okay, other things that can affect AMH, smoking. Now, you know, if you happen to have tobacco use disorder, it's actually pretty profound where when somebody smokes, their AMH goes down. And over time, when somebody stops smoking, their anti-Müllerian hormone creeps up again, almost to where it would have been without the smoking in the first place. So there is really a dose-dependent response. We also know that smoking can affect egg quality as well. And so just mentioning that, that is one of the modifiable things we can do to affect AMH. Also, weight loss can actually cause an increase in AMH. It's a little confounded by the PCO data, but basically, when somebody carries extra weight, you know, definitely in the obese category, we often will see that kind of in the upper quartile range of BMI that the AMH is actually very low. And I've seen this time and time again when women have meaningful weight reduction, that the AMH starts to come up, which is really, really interesting. We also find that response to medications is better in that situation as well. So definitely a plug for weight optimization if it's indicated. And then there's also seasonal variation. So it's interesting. AMH and vitamin D seem to be correlated together. In the summer months, we do find that women have higher AMH values. And then in the winter months, we do see that women have slightly lower AMH values. Now, is that correlated? I've never seen a study that looked at, you know, IVF success, whether done in the summer or the winter. But it is really interesting that AMH can fluctuate with our sun exposure and vitamin D levels. So anyway, so those are some of the things that can affect it. Now, what really is AMH, right? And how do we use it? I will tell you the number one way that I use it in my practice is looking at response to medications. So if you look at all of the data combined, the one thing that AMH has actually been shown to correlate with is response to medications in a clinical situation. So this means somebody is actually undergoing treatment with gonadotropins, either gonadotropin, you know, cycle outside of IVF or in vitro fertilization itself. And I use it with IVF dosing, right, of medication. So if somebody is, say, like 34 years old and they have an AMH of 8, for instance, I'm worried that they might over-respond to the medications and maybe even develop ovarian hyperstimulation syndrome. So that is somebody for whom, you know, when I look at my typical way of thinking about it, which is age and BMI, any previous stimulation results, if we have them, that is somebody where I would give them fewer gonadotropins than I might give somebody otherwise, everything else being equal. So we use it for that. We also, like, if somebody has a low AMH, then I am going to give them more gonadotropins than I might typically, because I'm worried that I may not get to their full ovarian potential if I don't use higher doses. And so, you know, I don't like to play catch up with my IVF medications. I like to recruit the whole cohort if I can from the beginning. And so, you know, depending on whether AMH is very high or low, I will usually adjust my doses accordingly. Now, you know, I also think about it in terms of risk for ovarian hyperstimulation syndrome. I do have a whole other podcast in OHSS. However, if somebody's AMH is high, I mean, studies vary, but like some studies even say over AMH of like 3.5, that people are at risk for this hyperstimulation syndrome. And so thankfully, we live in an era where we can use a Lupron trigger and we can use other adjuncts to try to mitigate the risk of this problem, which I used to see all the time in my fellowship. But, you know, it is one of the risk factors. High AMH is one of the risk factors for OHSS. So we do take that into account. Interestingly, I also use it in my letrozole cycles for patients with PCOS, because we know that people with PCOS tend to have higher AMHs than people otherwise matched for their age. And when I see a high AMH, like I said, sometimes it can portend sort of lack of response to oral medications. And so dosing of letrozole is like 2.5 milligrams, 5 milligrams, 7.5. If I see somebody with a high AMH, like, you know, 7 or 8 or above, I will probably not start them on the lowest dose of letrozole because I just don't think it's going to touch them. So that is another, you know, way that I use it in my clinical practice is response to oral medications. And obviously I watch those people like a hawk because I don't want them getting pregnant with multiples or higher order multiples. I also use AMH when I am helping people to decide whether to freeze their eggs or not. And I know this is very controversial, but if I see somebody and they're, say, like a medical student, so say they're like 28 years old and they have an AMH of like 0.8, they think they want a family someday, but they can see years of training stretching in front of them. Maybe they don't even have a partner. And, I might say, okay, well, your anti-Müllerian hormone is lower than I would expect for your age. So I don't know what your reproductive timeline is, but it may be on the shorter side compared to other people with everything else being equal. So, two data points is always better than one. Sometimes if, it's sort of on the fence, I might recheck in 6 months and see where it's going. But I have really watched people's ovarian reserve decline and even go away, even in the context of primary ovarian insufficiency, by looking at ovarian reserve in the context of desired fertility preservation. So these are things I don't take lightly. I am very clear to say AMH is not a screening test for fertility. It is not a fertility test. It is a quantitative assessment of ovarian reserve. However, I do think that trends over time can be helpful to help people make decisions about their future fertility. Now, to be clear, there is a study by Dr. Steiner from around 2013 that showed that people with low AMHs did not go on to have worse fertility outcomes later. And I think that's really important to say. However, like I said, if fertility is a priority for people and they may, have a lower AMH to begin with, I always talk about it because it's it's always really sad when you watch a physiological process that we can't recover from, right? And so knowledge is power. If somebody has a declining AMH and they really want a family someday, or maybe their sibling has infertility and they watch them and they don't want to go through something like that, they want some eggs, frozen, I think it's very reasonable to use AMH as a tool for counseling. um, and, also looking at anti-Müllerian hormone just in terms of like PCOS, diagnosis even. It's very interesting. The new ESRI guidelines did say that a high AMH could be considered one of the criteria for, basically not Rotterdam, but kind of in lieu of Rotterdam criteria. Very interesting because they did not define an exact value, which is probably because assays do vary. That's one of the limiting factors relating to AMH, is that there's different assays globally and it's really hard to have a unified standard. But anyway, anti-Müllerian hormone and the androgen follicle count on the ultrasound often do correlate with each other. So if somebody has like a lot of follicles on their ultrasound, they're probably also going to have high AMH. And that's really where I think ESRI is coming from when they say that, if somebody doesn't have an ultrasound to go by, you can look at their AMH. If it's high, then you can sort of in some ways substitute that for diagnosis. Okay. So I think by now we've talked about how AMH is really most useful in terms of figuring out, from my perspective as an REI, response to medications and IVF dosing, risk for OHSS, and also helping to counsel people in the context of fertility preservation. Now, what doesn't it do, right? And why is it not really a fertility test? Now, like I said before, AMH is a quantitative assessment of ovarian reserve. It is not a qualitative assessment of ovarian reserve. Really, there's no better test, so to speak. It's not even a test. No better data point to look at egg quality than age alone. And so not every single person will have the same egg quality at a certain age. However, what we do see is that, most 25-year-olds have good egg reserve. Most 30-year-olds have good egg reserve. Once people get to the mid to late 30s, the sort of the ovarian quality starts to diminish, right? Sort of, it's not just egg quantity, but it's egg quality too. And so, age is still the best predictor when somebody walks through my office doors of whether I can help them. And, even in the context of having a low AMH, age is still the most important factor in terms of helping somebody to, meet their goals. Now, if somebody is 42 and they have an AMH of say 5, I'm a lot more likely to be able to help them than somebody who's 42 with an AMH of 0.5, because, like we said, like if over the age of 40, over 80% of the eggs are already abnormal, it's a lot easier to get to a good egg from a large number of eggs than from a smaller number of eggs. And that is usually true. So, if somebody gives me 10 blastocysts in an IVF cycle, it's a lot easier usually to get a normal one from that compared to, somebody who might give me 0 to 1 blastocyst per IVF retrieval. So that's sort of how I think about it. And I also think that when we think about literature about AMH, especially as it pertains to people who have received chemotherapy. There's actually really good data that even people with undetectable AMHs can still conceive pregnancies. And so I don't want anybody to think that this is a infertility test per se. It does speak to physiology and how many eggs are left in the remaining pool of eggs, because unlike men, we're born with all the eggs we'll ever have, and we lose them slowly over time. Maybe in the future, we'll be able to take a fibroblast from our, peripheral tissues and turn it into an oocyte. I know many people are looking at in vitro gametogenesis, but, as of yet, we're not quite there. And so until then, we must rely on what we have in our ovaries and the choices that we make with those cells. So to review, we talked about what is AMH, hormonally speaking, how do we use it, and why it doesn't necessarily equate to fertility. I hope this has been helpful. I do understand that what people are craving the most at this time is scientific knowledge about the nuances of their values, of the treatment options. And so, I love you. If you have more topics, sciencey topics for our science series, please let me know. I'm always happy to talk about sort of the frontiers of care. Until the next time, bye.